In name of the event team, we want to welcome you for this international webinar, Innovations in Fetal Therapy. We are really excited, so many people registered and are looking forward to a very interesting, but most of all, inspiring afternoon. I am Joanne Verwij, and next to me is Femke Slaghekke, both maternal fetal medicine specialists at the LUMC and part of the fetal therapy team. If there are any problems, you can contact us via Fetal Therapy at lumc.nl. And we are forced to describe the webinar rules to make it a smooth afternoon. So please mute your microphone. If possible, also put up your video or your visual camera. We really welcome interaction. So you can ask questions via the chat function of Zoom. There's a whole team available to moderate the questions. And if you want to ask an oral question, this is also possible, but we really request to ask it beforehand by waving the hand via the Zoom function. I want to start with a short introduction. The Leiden University Medical Center is home to the National Fetal Therapy Center, established in 1965 by Professor Jack Bennebuck-Graafhorst, one of the world's pioneers in fetal blood transfusions. Many years passed since, and for the last decades, our team provides unique and innovative care in the field of fetal therapy, and is able to do so by intensively collaborating with international institutions. In this light, we like to thank Dick Oepkes, as he has an important role in national and international collaborations for our team. As you can see on this slide, the fetal therapy is a real team effort, and we are very fortunate to have a great team available 24/7 in the LUMC. This expert event, hosted by the LUMC Global program, will showcase the latest innovations, but we hope not to only give you insight in these latest developments, but also spur you on to connect with us and build up a community to improve the care for the tiniest and most vulnerable patients even further. We wish you a very pleasant and interesting webinar. And now I'm happy to present the first speaker, Roland Devlieger. He is head of the maternal and fetal department of the KU Leuven in Belgium. We know him for a long time. One of the highlights was his fellowship in Leiden. But we also plan congresses together, preferably combined with a nice trip. For many years, we worked together in the Northern Alliance, a collaboration LUMC Leuven and the Karolinska Institute. And within this collaboration, we do research, but also have audits about our clinical work and improve our treatments. In the coming year, we even start with a joint PhD. We are very happy he accepted the invitation to give his presentation as an international expert on a very interesting and innovative field in fetal therapy, Fetoscopic treatment of fetal spina bifida. Roland, the floor is yours.
Thank you very much, Joanne. If you stop sharing your screen, then I can start sharing mine. Can you see it all right and hear me all right?
Yes.
Okay, Thanks very much for the kind invitation, and it's always a pleasure to see my Leiden friends. I will give this talk on behalf of my colleagues Jan de Prest and Frank van Kallenberg, and especially Dr. Luc Joyeux that performed a very beautiful PhD on this subject and lent me a lot of nice material for this presentation. In 1991, the IFMSS defined some criteria that need to be fulfilled for a condition to be a subject for fetal surgery. And that is that we need to know the natural history. We need to have accurate prenatal diagnosis. There has to be no curative postnatal alternative. And there need to be a lot of experimental and clinical evidence for the feasibility, but also especially for the maternal safety of these procedures. And then finally, the intervention needs to be performed in a multidisciplinary fetal center with ethical approval. And I will take you through the story of fetal repair for spina bifida and the fetoscopic approach that we now have reached. Spina bifida aperta is the most common neural tube defect, and it can present either as a meningomyelocele or a myeloschisis, as you know. The prevalence is about 5 cases per 10,000 births in Europe, and slightly less in the States, where they have fortification with folic acid in nutrition. It is a non-lethal condition, but with a severe progression in utero with a pathogenesis that is in 2 steps. First, we have the anatomical defect, that is the non-closure of the neural tube defects happening early in embryogenesis. But there is what we call the second hit, that is direct trauma to the spinal cord, to exposure to the amniotic fluids, but also due to the CSF leakage, there's hindbrain herniation and ventriculomegaly, which then will in turn give some neurologic impairment. The diagnosis is accurate. These days, we aim for first trimester diagnosis of neural tube defects, and you see that using high definition ultrasound, most of these lesions will be diagnosed in pregnancy, either by seeing the direct spine signs at the lesion or with indirect signs at the level of the fetal brain. What we also know is that there is a high termination rate. In countries that allow termination, these rates vary between 30 and 100%. There is also no effective postnatal therapy. Once there is a lesion, these children will have a progressive and chronic handicap. The motor lesions are the roots between L3 and S1 especially. And we also know that there will be adjacent lesions to the spinal canal, which will impair the sexual function, but also the voiding capacity and continence. Additionally, due to the hydrocephaly and hindbrain herniation, there's also some damage to the cranial nerves and some ocular and vagal problems. So this is a very severe condition that we have in the postnatal care no cure for, and that leads to an excess mortality in these children. You see that we don't only lose children in the early neonatal period, but there's also a progressive excess mortality throughout the years. And therefore, in view of that dual hit pathogenesis, in the late 80s, people have been starting to perform animal experiments to try to mimic neural tube defects and cover them in utero. And there's a broad experimental basis that this works. And therefore, at the end of last century, the first human studies have started, and this has led to the well-known MOMS trial, which is a randomized trial that compared fetal spina bifida repair versus postnatal treatment in a open repair setting. And you see the inclusion and exclusion criteria. So the only lesions that were operated in this study were severe lesions at the level T1 to S1. As I said, this was open fetal surgery repair happening between 19 and 26 weeks. That included a broad laparotomy to expose the uterus and a layered repair of the spine defect to arrest further damage. And here you see how this is performed now in clinical practice. A stapler is being used for a bloodless hysterotomy. Then the fetus is positioned and anesthetized. We do then a layered repair of the spinal defect as this would happen in postnatal life. And finally, once the fetal skin is being closed, then there is a uterine closure with 2 layers that is performed to have this all watertight and safe for the mother. What were the results of that MOMS trial? Well, in terms of efficacy, there was a spectacular reduction of the children that needed a shunt placement after birth from 84 to 44%. And another spectacular improvement at 30 months outcome was that the number of children that could walk independently doubled from 24 to 45% in the operated children. In the meantime, we also have the 6-year outcome in these children, and there also the number of children with volitional voiding increased from 4 to 24%, so an important functional gain there as well. Also, we know that predictors of ambulation in these children have been identified, like leg movements, the myeloschisis type of lesion, and lesions below L3. But also, there is some invasiveness related to this procedure, and that results in a significant number of babies being born preterm. Mean gestation at birth is 34 weeks after open surgery, and prom rate as high as 46%. Additionally, there are some maternal risks like pulmonary edema, uterine dehiscence, and hemorrhage, which will increase the complications not only in the index pregnancy, but also in future pregnancies. And especially the uterine dehiscence is something that surgeons operating on this uterus are afraid of. So therefore, people quite early have been looking at fetoscopic alternatives for this spina bifida repair. And the aim, obviously, is there to see whether we can reduce the morbidity in the mother, in the fetus, improve the obstetrical outcome without compromising the neuroprotective outcome. And 2 fetoscopic approaches have been developed throughout the years. And the first one is the percutaneous approach. And there we have a direct access percutaneously through the maternal skin, maternal uterus, directly in the uterine cavity to operate on the fetus. They have been developed by Cole and colleagues. And the problem here is that you have a reduced maternal morbidity because you don't perform a large laparotomy, but technically you have less space to work, and especially in case of an anterior placenta, the placement of the trocars is technically enormously challenging. So a more modern approach, although more invasive, is the laparotomy-assisted procedure that was especially developed by the team in Baylor, and they use a laparotomy to exteriorize the uterus, inflated then with CO2 to create more working space and being able to enter the uterus either at the front or at the back, depending on the position of the placenta. And this is a increased maternal morbidity, but technically it's probably easier to perform a watertight closure of the defects. And to show you the invasiveness of laparotomy and exteriorizing a uterus, this movie to show you that this is some invasive procedure with potential morbidity to the mother, and needs to be performed only if the clinical results are much better. And we can compare these clinical results with the published series. Percutaneous fetoscopy, in terms of effectiveness, we have shunt placement rates that are slightly higher than in the open moms trial. And in terms of walking ability, we have comparable results. Unfortunately, we do not have long-term functional bladder function results in these children. In terms of invasiveness, unfortunately, when we look at percutaneous fetoscopy, the results are not good. Compared to open fetal surgery, this pregnancy will lead to even more prematurity. You see prom rates around 80 to 85%, resulting in a mean gestational age at delivery of 33 weeks. Of course, the maternal complications are less than in open fetal surgery, although some cases of pulmonary edema have been described, most probably related to the length of the procedure. And then when we look at the laparotomy-assisted fetoscopy, in terms of effectiveness, the results there are very good. The series that have been published by the Baylor group show shunt placement rates of 33% and a 93% reduction in hindbrain herniation. At 30 months, we do not have a lot of information, but the first results that have been published, they show that 77% of these operations lead to a functional gain of 2 or more levels. But there again, we do not have long-term functional urologic outcome in these children to compare with. So globally, it seems like the additional invasiveness of the laparotomy-assisted fetoscopy is worth doing when we look at the clinical results that are being obtained. And through the invasiveness, there's even more evidence. We see here that gestational age at birth in the laparotomy assisted is almost 38 weeks, so almost comparable to postnatal treatment, with a reduction in the prom rate from 46 to 29% without any reported important maternal morbidity. So even more promising. We decided to go for that laparotomy assisted fetoscopic approach, but at the same time, the work of Luc Joyeux has shown that an important factor to obtain good results is the surgeon's experience. And in his thesis, he did a very nice custom analysis of the number needed for a good learning curve and for the open repair. The custom analysis extrapolated that 35 cases are required, but for fetoscopic repair, even 56 cases are a minimum to obtain good results in terms of timing and watertightness. So it shows that there's an important learning curve for this complex procedure. And therefore, also part of his PhD, he developed a multi-step training program, starting on a pelvic trainer, then going to rabbit cadavers, live rabbits, fetal lambs, which in terms of size and material are comparable to the human situation, and then a off-site and on-site training with mentors that are used to perform these procedures to obtain a fully trained surgeon. And so we did, starting from training on rabbit models from 2016 onwards. We then moved to the sheep model in 2017 to be able in 2019 to start our clinical fetoscopic model. And what I want to show you with these clips is that the material and the procedure can be mimicked very nicely in these models. For example, in the rabbit model, we use the stomach to perform a patch placement, and the thing we cannot do in human is to check afterwards using fluoroscopy whether the repair has been completely watertight. But this is a nice way to improve your operative skills and to become able to perform that difficult surgery in human. So these are the different steps you see on top, the setup of the material, and there's quite a lot of material required, especially when you compare to the other type of fetoscopies that we do, for example, for TTS. Second step is then to exteriorize the uterus, to place the ports at the right position and angle, and to inflate the uterus with CO2. And after that, you can start the bilayered repair by dissecting the lesion first and then by covering it. If necessary, that is performed with a patch. Otherwise, we prefer to have myofascial flaps. And then here, finally, the skin is closed and the whole team, including obstetricians, fetal surgery specialists, anesthetists, and neurosurgeons is tired after this procedure that take about half a day. This is a technology meeting, so I want to end with some future research directions, and the most important upcoming development that we are working on in the experimental lab is to develop single port fetal surgery. Indeed, if we want to further reduce the invasiveness and improve the results, working with a single entry will probably be the most efficient way. And there are some robotic arms, including multiple instruments and a scope that are on the market, but their diameters is at least 25 millimeter with no automation and the absence of haptic feedback. And that's what, in collaboration with the Department of Mechanical Engineering, is being worked on, supported by the Wellcome Trust. We are now working on 12 millimeter entry instruments with fully automated camera control and force sensing and haptic feedback. That is what we want to achieve. I show you one of the latest prototypes where you see that not only can you have surgical instruments, but also laser fibers that are being introduced and manipulated while having a single small entry in the uterus. So a couple of take-home messages. Fetoscopic spina bifida repair is feasible and safe via exteriorized uterus with heated humidified CO2 under controlled anesthesia. Short-term outcomes are promising. The long-term outcomes of fetoscopic technique are currently lacking, should be compared with the open MOMS results. And in view of the technical complexity, the long learning curve, and the relative rarity of the eligible patients, the clinical care should be concentrated in high volume centers and managed through national and international collaborations. Again, thank you very much for the invitation. I want to thank also all the people that work on this project, especially the colleagues in Jan de Press team in Leuven, but also people in London, Anna David and colleagues, the people in Texas, Michael Belfort and colleagues. Thank you very much.
Dear Roland, thank you very much for your very interesting presentation. I think there was only one question, and Dick Oepkes would like to ask you one question. So Dick, he's in the other room.
Thank you very much, Roland. It's an impressive body of work that the Leuven team, in collaboration with a lot of friends and colleagues from around the world, have been doing and are still doing. Exactly what this afternoon is about. I have a brief question on the reason or the reasons to perform fetoscopic surgery for this indication would be potentially reducing the risks of future pregnancies for the mother. Is that correct?
Yes. When you have the open approach, you have a incision that is at least 4 centimeters. And after that, in not only in the index pregnancy, but all later pregnancies, the patients are led to cesarean birth. If you go for endoscopic approach, it has been proven that you can have a vaginal birth both in the index pregnancy as well as in later pregnancies.
Yeah, sure. So my question then is, if a woman is sure that this pregnancy with the spina bifida fetus is her last pregnancy, it would be very logical for her to request open surgery, because almost by definition, the quality of surgery for the fetus and for the child will be better. Or am I missing something? Is it possible to discuss these options with the patient and say, when you're 18 years old and you want 6 more children, you would never do open surgery, but if you're 42 and it's your last child, you would be crazy to do fetoscopic surgery?
Well, what I try to show is that the dexterity of the fetoscopic surgeons to repair these lesions have now almost mimicked completely what we do in open or postnatal repair. And then in fact, the results in terms of water tightness and functional repair are comparable. So still probably if you have a good fetoscopic team and the results are comparable in terms of risk for example, infection or abruption or bleeding, there is still an advantage to stick to the fetoscopic approach.
Thank you, very clear.
Thank you very much, Roland and Dick, for your question. We first need to apologize for the ding-dong that many of you were hearing. It had to do with the setting regarding so many participants that were joining us. So we're really happy that so many people are joining us. And we found the button to undo the ding-dong, so hopefully we won't hear it anymore. Now I would like to present our next speaker, which is Dick Oepkes. And actually, we have to thank him for we have this global LUMC international webinar. As you can see, he will be standing there to present. Dick Oepkes is a maternal fetal medicine specialist and also a fetal therapist. He's about to retire, but luckily he's still here today. He built up a huge network nationally and internationally, and which giving us benefit every day. And he meant a lot for the fetal therapy in the Netherlands, but also internationally. And thanks to Dick, we will shortly have no work anymore, because one of his life goals is to replace invasive treatments for non-invasive options. An important achievement that he has made was the implementation of NIPT in the Netherlands, because now it's available on a non-commercial level for everybody in the Netherlands. And therefore, we saw an important reduction in the amount of amniocentesis that we do. And now, possibly, there will be an end of the intrauterine transfusions that we perform. So today, he will present on the use of a very innovative new treatment called nipocalimab. And Dick, please present your beautiful work.
Thank you very much. Zie ik ook mijn... Yes.
Ja, Oepkes webinar, daar staat hij.
Share.
Yes.
Wel even boven. We get this right. Oh. What is this? Yes, let's start at the first slide. That's always nice. And to reassure some people, I saw a question coming by from Baski. There will be room for more discussion at the end of all the presentations. So if you have more questions on spina bifida repair, for instance, there is still the opportunity. Again, thank you, Femke and Joanne, for the invitation. And this presentation will be on one of my favorite topics already for the last 30 years, the management of pregnancies with allo-immune disease, especially hemolytic disease of the fetus and the newborn, or rhesus disease, or red cell allo-immunization. There are a lot of terms for the same thing. HDFN is the abbreviation that now becomes more and more in fashion, hemolytic disease of the fetus and newborn, and that's what I will mostly use in this topic. And I think most of you are very familiar with the problem. The start of the whole process is an incompatibility between the mother and the father, which causes the problem of allo-immunization when cells from the fetus cross to the mother's circulation. Then mothers can make, or pregnant women can make antibodies of the IgG type. And these IgG allo antibodies cross the placenta, and that is by a process which you see depicted on the right. That is important for the next part of the talk, to understand that these IgG antibodies do not cross completely passively the placental barrier. They are taken up by a receptor called the FcRn receptor, and they are dropped into the fetal circulation on the other side of the syncytial trophoblast layer. Then when these antibodies are in the fetal circulation, they destroy the erythrocytes, and anemia develops, which can lead to hydrops and fetal death. Or if the fetus survives, then the neonate can be severely ill by hyperbilirubinemia, can icterus, cerebral palsy in survivors, the terrible consequences of this disease. And it may not be so well known that this disease actually worldwide is still a major problem. It's in our sophisticated Western society sometimes considered a very minor disease because of the prophylaxis programs. But very recently, 2 months ago, there was a publication from FIGO, the International Organization for Obstetrics and Gynecology. They described a guideline to help improve the prophylaxis programs, especially in lower and middle income countries in the world, because they made it very clear that at least in about 50% of cases, there is a very low uptake of this prophylactic approach worldwide. And my friend Jerry Visser is leading a consortium to try and eradicate rhesus disease worldwide by focusing on screening and prophylaxis programs in the less developed countries especially. And they have calculated in this article that worldwide, rhesus disease still results in more than 160,000 deaths of fetuses and neonates, and 100,000 cases of disability every year. So it's still disappointing on a large scale what this prophylaxis program can do. And of course, this will not change on very short notice. Therefore, for many years to come, we will be confronted with pregnant women with rhesus disease or allo-immunization caused by CAL or little c antibodies. And therefore, we still need treatment of these pregnant women. As you know already, for a number of decades, we have the possibility of intrauterine intravascular blood transfusion. It is sometimes called the mother of all fetal therapy. It was one of the first examples of treatment of sick fetuses in the womb, invented in the early 60s by William Liley in New Zealand. And the technique that is used today has been more or less the same for the last 25 years or so, and has become more and more successful. Still, there is what they call an unmet need. There is a problem with this invasive procedure in terms of unsuccessful cases, adverse outcome. And this was summarized by Caroline Zwiers from our department in a publication a few years ago, where she combined series from larger centers around the world that looked at their complication rates of intrauterine blood transfusion. And if you look on the right side at the bottom of the table, it's summarized that the procedure-related fetal loss is in the order of about 2% in these pregnancies overall. And this is not equally distributed. There are groups of patients that have an increased risk of adverse outcome and fetal death. And one of the biggest influences of these risks, one of the most important predictors of poor outcome is the gestational age at the first transfusion. So the women with the most severe form of HDFN, they may require transfusion even before 20 weeks gestation. And then Caroline Zwiers in another publication showed that the risk of fetal death is more than 8% in these cases. And several other series showed the same or even worse outcomes. And of course, it's important to remember that these series of outcomes are usually published by centers with high volume, a lot of experience. The best centers publish their results. The real world data are usually less favorable than the published series. Apart from gestational age at first transfusions, it's clear again and again that experience of the operator and the team plays an important role as well. Shown by several publications, shown here, Eleanor Tibblad summarized a large series where one of the few significant parameters to influence outcome was the year of intrauterine transfusion. So the earlier years of a center usually mean a poorer outcome. And in our own center, we also showed a clear correlation between the experience of operators and their outcomes. And what may play a role in the near future is the reduced experience by operators in needling procedures, the amniocentesis and CVS procedures that many of us have done so many times are rapidly decreasing in numbers. And what we used to do in Leiden for many years, the transfusions were planned on Thursday afternoon, and then the same operator would perform 10 or 15 amniocentesis or CVSs in the morning to sort of get a feel again for the procedure, and then move on to the 1 or 2 or 3 transfusions in the afternoon. And that sort of procedure experience is rapidly declining nowadays, which is of course a good thing, but is a problem for the safety of these procedures. So what has been tried to improve the outcome of women that require intrauterine transfusion, especially the early group, was treated by intravenous immunoglobulins, IVIG, started early in the first trimester, was thought to increase the possibility that the first transfusion would be needed later in gestation. So when the history of a previous pregnancy was severe, so a transfusion or a fetal death before 24 weeks in this publication, they looked at the possibility that IVIG would postpone the gestational age of the first transfusion. This turned out to be not really the case. If you look at the table, gestational age at first transfusion, more or less the same, death rate the same, intact survival after 32 weeks, about 75% in both groups, so quite disappointing. And again, showing that this group especially has a poor outcome. And a similar study was published by the same Caroline Zwiers that I mentioned, that you see her on the upper right corner, together with Jack Bennebroek-Gravenhorst, the founder of Dutch Fetal Therapy, at her PhD event where she received her PhD for this work. She collaborated with quite a large number of colleagues around the world to get these data of a similar group with an early severe hemolytic disease in a previous pregnancy, and then treatment by IVIG in the subsequent pregnancy. And you can see on the graph that the IVIG group, the red dots, in only a few cases managed to have the first transfusion after 24 weeks. The majority was still early in pregnancy. The non-IVIG group all needed transfusion before 24 weeks. So there seemed to be some effect, but overall, the postponement was an average of only 15 days, and the outcomes were similar. So quite disappointing. What could be done to improve the prognosis of fetuses that require intrauterine transfusion is the blocking of the IgG transport over the placental barrier, a concept that was considered a long time ago, but only recently a medication was invented that meant to do this in particular, to block the FcRn receptor, therefore preventing the fetus to have these IgG antibodies in the circulation. Therefore, the fetus and also the neonate should not become ill at all. That is the principle behind this treatment. And the drug that was invented especially for this indication was called M281 by the company Momenta, and is currently named nipocalimab, a monoclonal antibody designed to block this FcRn receptor. It's a fully human antibody with a very high affinity for the receptor. And this, of course, deserved to be tested. How does it work? So one mechanism of action is by blocking this receptor and therefore preventing the antibodies to enter the fetal circulation. The other part of the mechanism is to prevent the reuptake of the IgG in the maternal circulation, which is also regulated by these receptors, that leads to a significant lowering of the IgG levels in maternal blood. So all IgG, including the pathological IgG in case of allo-immunization. So these two mechanisms together could significantly reduce the risk of the fetus becoming anemic. Of course, a lot of preclinical work was done to show what needed to be shown before it could be used in real patients. In the graph, you can see the mechanism of action starts very rapidly, almost immediately. The receptor is occupied almost 100% level. And when you stop the drug, it quite quickly goes back to normal again. Animal studies have been done, human volunteer studies have been done, and all these data made it possible to start a study in the real patients that would need this drug, and that is called the Unity study. So nipocalimab to prevent or minimize HDFN. The objective of this, of course, first in human patient study was first to evaluate the safety, both for the mother and for the fetus and neonate, and also the child later on. And secondly, of course, evaluation of the efficacy of the drug as measured by the proportion of patients that have a live birth after gestational age week 32 without needing an intrauterine transfusion. That would seem a nice goal to have. The inclusion of this first study was chosen to be the severe group, the same group basically that was described in the IVIG study. So women that had a previous pregnancy in which the fetus needed a transfusion before 24 weeks or died from Rhesus disease before 24 weeks. The study design is shown here in this timetable where screening of the pregnant woman and the fetus, of course, that needs to be antigen positive, takes place before about 13 weeks. And then if the woman is really eligible and signs the consent form, the drug can be given weekly from week 14 onwards. And it will be stopped at 35 weeks. Then induction of labor or C-section, if needed, will be done 2 weeks later to give the drug time to wean off and to have an adequate IgG level in the mother and possibly also in the neonate in case of infectious challenges. That, of course, is the major risk factor, at least theoretically, that if you lower IgG levels, there might be an increased risk for infection. Therefore, it was chosen to stop about 2 weeks before birth to have some IgG levels back. And then mothers and children will be followed for a long, and in case of the child, for a very long time. This group of patients is quite rare. The severe early onset HDFN group, we also see only 1 or 2 cases of those per year. So we really needed international collaborative study design. And you see here all the centers for fetal therapy around the world participating in this study. And especially like to mention one of the founders and organizers of this study and the use of this drug, Ken Moise from Houston, Texas, with the Johan here on the left. Ken is really the driving force clinically for this whole study. And I think what I need to do at this time is, if this study becomes a success, it's still ongoing, to apologize to Femke and Monique and Johan, because it may well make blood transfusions completely superfluous. It's, of course, an ongoing study. I cannot give you any results at the moment, but the goal is to make Rhesus treatment completely safe. And fortunately, the group can still continue to do fetoscopic work, laser surgery for TTTS and other nice things to keep us all happy as fetal surgeons. Then lastly, is this drug potentially useful for other diseases? Of course, there are other IgG-mediated diseases where maternal IgG antibodies cross the placenta and cause fetal disease. Fetal and neonatal allo-immune thrombocytopenia would be a logical candidate, and there are some others, congenital heart block, for instance, that may benefit from this drug if it is shown to be successful in this Unity trial. And with this, I would like to thank you and promise you to come back with the results once the the trial has been finished. We're about a bit more than halfway, so have some patience, but we will stay in touch, and all the collaborators in this study, thanks very much. And I hope there is still some time for questions. And then also at the end of the presentations, we will again have some time to maybe go over some more items for discussion. Thanks very much.
Thank you very much, Dick, and apologies accepted. We're more than happy to continue with this research, and the most important goal is to improve outcome for fetuses at risk. So we definitely will continue that. I see in the chat there are a couple of questions. So my suggestion is that we will first start with the questions for Dick, and after that there might be a little bit time for the questions for Roland as well. So one of the questions is by Gerard Visser. Dick, can you elaborate somewhat more on the potential side effects of this new treatment? Are there any animal data?
Yes, thank you. Of course, with such a new drug, side effects are very important. We now seem to worry about side effects that happen in only 1 or 2 in a million of cases with the COVID vaccines. That is not the numbers we can show here, but the side effects that theoretically concern most that learn about this drug are infections. And it's important to realize that only the IgG is affected. It is lowered in the maternal circulation to a level of about 15 to 20% of baseline. The other IgGs are not affected, and also the production of IgG is not affected. It's the reuptake. So there should still be, if there was an infectious agent attacking the mother, so to speak, then her ability to react by increasing the level of IgG would still be there. And for neonates, the normal physiological situation is that the neonate has an IgG level in its blood at birth, and that may be lowered with this type of treatment. That also is the only Ig, so other Igs are present and unaffected. And if the cord blood IgG level, which is measured immediately after birth in this trial, is low, then IVIG can be given immediately to increase the level back to normal. So it's a theoretical risk, but can easily be ameliorated with the right management. And in the monkey data, for instance, there was no infection. On the volunteer group, there was no increased infection risk. So it looks like a minor issue in clinical practice.
Thank you very much, Dick. There's only one other short question. Maybe you can give a short answer. What will be the potential costs?
I have no idea. No idea.
That's a very short answer. Thank you very much.
Yeah.
Okay, then there was for Roland Devlieger. Baski had a question. I think please unmute yourself to ask the question to Roland.
Thank you very much. I'm so sorry. Thank you, Dick, as well. I think they've asked you all the difficult questions. Roland, twice in 1 week. Thank you for your presentation. Really, really good.
Thank you, Baski.
And very convincing. When you counsel women, do you talk to them about the benefits of fetal surgery on hindbrain herniation, or is that not part of the discussion you have with them?
Hallo, Thomas Huislissen met Karen.
Yes, thank you, Baski. Of course, this is part of the let's say short-term outcomes that we discuss with the patients. So really, the immediate short-term neurologic outcome includes the hindbrain herniation and the shunt placement. These are the main two, let's say, short outcomes that we discuss with them. And then we have, let's say, the 30-month outcomes, including the walking ability and the functional levels. This is the second important step in the counseling of the patients. Yes.
I think the reason for the question about hindbrain herniation is that it's a temporal trick. If you look at the 200 odd surgeries that have done postnatally in our unit in the last 20 years, 95% of hindbrain herniation at birth is resolved by surgery at the time or just immediately after birth. So what when we quote or cite hindbrain herniation improvement of fetal surgery, it's a temporal effect because you're operating pre-birth, the hindbrain herniation disappears before birth. When we operate post-birth, the hindbrain herniation resolves post-birth. In our cohort, only 6% of babies had required surgical compression for hindbrain herniation. So
you're stressing, it's an important point to stress. And I think on its own, it's not the only valid counseling point. And you should certainly take into account the shunt placement, for example, which for the parents with the recurrent placement blockage and replacement is an important morbidity factor.
If I could just talk about some shunt placement, one of the concerns we have about shunt placement is that unfortunately, pediatric neurosurgeons don't have very strict criteria for deciding who does or doesn't need a shunt. So in our own unit, shunt placement without fetal surgery is around 50% and not 80 to 90% as it is in USA. So with the lack of that sort of strict criteria for placing shunts, I think it's very difficult to measure it as a strict or a fairly rigid outcome because it could vary tremendously depending on who the surgeon is postnatally that looks after the baby and their awareness of what was done before birth and then perhaps their reluctance to place a shunt if there's been prenatal surgery. So and that's my only concern, but I think an RCT should answer that very clearly.
Yeah, I think you're raising a good point. The intensity and the follow-up is absolutely crucial. Also, in reporting the outcome, we should have clear criteria how the different studies report the different outcomes. Yeah, absolutely.
Well, thank you very much for this discussion. Martin Walker is raising his hand. Can you please ask a very short question?
Yes, Roland, do you have open surgery as a backup for your fetoscopic surgery?
That's a very important question. We have a very active open fetal surgery program with about 100 procedures that we've performed, and it's absolutely necessary to have first the open experience before going to fetoscopic, because a lot of aspects to the operation, including maternal anesthesia, uterine relaxation, fetal resuscitation, positioning, and so on, are absolutely comparable in the two operation modes.
Thank you.
Okay, thank you very much for that question. Then I would like to continue with the program with our next speaker, which will be Anna David. And I'm really happy that she accepted our invitation. She's the director of the EGA Institute for Women's Health at the University College of London. And she's also a maternal fetal medicine specialist and a pioneer in new treatments for fetal growth restriction using maternal gene therapy. She's also the pioneer for the first clinical trial of the in utero stem cell transplantation of brittle bones, known as the Boost Before study. With other European parties coordinated by the Karolinska Institute, we work together in this Horizon 2020 project. So we are very honored and delighted that she will present today on the Boost Before study. Okay. Anna, do you want to share your screen and start presenting? Unfortunately, we don't hear you.
Joanna and Femke, you might be muted. Anna, David, are you still on mute?
Sorry, can you see my screen? Can you see my screen now?
Yes, yes, we can.
Oh, perfect. Okay,
Thank you.
sorry about that. Yes, thank you very much, and thank you for the invitation. It's great to talk to you, and this is very much coming on behalf of everybody in the Boost Before Consortium, particularly Cecilia Gottestrom, who's the chief investigator. So I'm going to give you an update of where we are with this innovative trial. It's very much based on this idea that in fetal therapy, one needs a certain diagnosis, there's a predictable natural history, and that if you could treat a genetic condition before birth, you may actually improve the outcome. And that follows on from what Roland said about relevant to fetal surgery for spina bifida. So we know fetal surgery is commonly done for lethal structural abnormalities or those that might have benefit from treatment in utero. But there are many, many single gene disorders, hematological. We'll be hearing from Tippi Mackenzie later on today about alpha-0 thalassemia. There are metabolic conditions that might benefit from in utero treatment because they start in utero. And I'm going to talk to you today about skeletal abnormalities, in particular severe osteogenesis imperfecta. So if we're talking about genetic conditions, they are actually relatively common if you group them together. So probably around 50% of the total cost of children's admissions to a pediatric hospital is related to single gene disorders. And they're very common, and many of them are being treated postnatally by stem cell transplantation. About 30 to 40,000 transplants annually worldwide, mostly bone marrow, now moving to umbilical cord blood, and also peripheral blood as well. And it is highly effective, but there are limitations to giving stem cells for single gene disorders. Postnatally, certainly for hematopoietic stem cell conditions such as sickle cell or thalassemia, you need to condition the bone marrow, you need to give long-term immunosuppression, and only about 30% of individuals have an HLA matched donor. And so existing therapy is complex, expensive, and possible in only around 10 to 15% of cases. So I'm going to talk to you about osteogenesis imperfecta, which is a single gene disorder affecting the bone. And this is a case that we had a few years ago. This was a lady who was in a consanguineous relationship, had a previous term delivery, uncomplicated, and then in her second pregnancy had presented at around 30 weeks with a baby that clearly had a severe skeletal dysplasia. And the fetal post-mortem confirmed osteogenesis imperfecta type 3. She'd not seen a geneticist following treatment, that pregnancy, and was seen locally at 9 and 12 weeks, had a slightly thicker nuchal translucency, but a low-risk combined screening test. And her anomaly scan locally had shown short fractured long bones. And it was very likely that this was recurrent OI, and she was offered a termination of pregnancy. And she was referred to us at UCLH because she was interested in prenatal treatment. And there had been a few case reports at the time done by the Karolinska Institute. And there are some typical scan findings. You can see down on the bottom right, this very bent femur, and the humerus is very short. And you can see over to the left-hand side, the graphs. And really, these long bones are very, very short. But if you have a look at other parts of the baby, so for example, the abdominal circumference, the head circumference, they're all in keeping with the gestational age of the child. So what is OI? It's a single gene disorder associated with the structural protein collagen, 90% type 1, and collagen is absolutely vital for normal function of your skin, tendons, vasculature, and organs. And there are two genes. The COL1A1 gene produces the pro-alpha-1 chain, and the COL1A2 gene produces the pro-alpha-2 chain. And you form your collagen with 2 alpha-1 chains and 1 alpha-2 chain to form a triple-stranded pro-collagen molecule. And this undergoes post-translational modification and cross-linking, much of which is done in the Golgi complex, and is then produced into the extracellular matrix, where it undergoes cross-linking and fibril formation and essentially forms normal bone. And if you have problems with either one of these genes, then you have abnormal collagen formation. And this can result in the typical abnormalities. Here you can see the blue sclera, you can see the bent bones, problems with teeth and height as well. Now, different types have different outcomes, the most severe being type 2, where about 20% have an intrauterine death and 90% die by 4 weeks. And type 3, previously, around 2/3 of children died less than 20 years due to chest wall deformity, but it is now treated with cyclic intravenous pamidronate, and that has improved the outcome. Majority of patients will survive into adult life, but they have multiple problems, often to do with fractures. So they need to have rigorous physiotherapy, occupational therapy, multiple fractures with orthopedic surgery. There are a number of treatments that you can see here on the left-hand side, but much of this is merely palliative, doesn't actually really improve the long-term outcome. And children end up having splints as well. And so it's possible to make a prenatal diagnosis. This is some data from Lynn Chitty's work, essentially showing how you can differentiate between the different types depending on the severity. So for example, Osteogenesis Imperfecta type 3, the forearm may be short and bowed, and maybe this, but it may be normal in early pregnancy. So it's not guaranteed that when you see this normal bones in early pregnancy that it doesn't have OI. So it is possible now to do prenatal diagnosis with genetics. There is available, for example, a 240 gene skeletal dysplasia panel, and next generation sequencing is available on amniotic fluid or chorionic villi. Ideally, both parents and the fetus are sequenced as a trio. And the Boost Before study has been developing non-invasive prenatal diagnosis to aid this sort of way of screening and treating. And autosomal dominant cases are usually sporadic. So why would you transplant stem cells before birth in this condition? Well, the aim would be to try to prevent irreversible damage. We know that these fractures occur in pregnancy, and you may not be able to completely remove the fractures, but you may be able to actually improve the bone structure itself. There is better delivery via the umbilical vein with mesenchymal stem cells. If you try to inject mesenchymal stem cells peripherally, postnatally, they do actually fetch up in the lung. They migrate through the pulmonary circulation, and then they're very often sequestered in the lung. Whereas in the fetus, an umbilical vein injection of mesenchymal stem cells would actually pass through the lungs, avoid the lungs, I should say, and actually go into the central circulation. It's also possible to take advantage of large stem cell migration that happens in the fetus. There is this idea of a naive immune system. So the idea that if you expose the fetus to foreign cells postnatally, they will be less likely, the individual will be less likely to mount an immune response. And you can give a large cell dose, and that's very important because these stem cells are really expensive to manufacture. So you'd be able to give a larger cell dose compared to the size of the fetus. And then there is the final psychological aspect that you're able to give parents some treatment if they are committed to continuing to the pregnancy. So the idea really is to use mesenchymal stem cells because these are bone forming, they're easy to isolate and expand, they have low immunogenicity, they have a very stable genotype, they're easily able to expand in vitro, and they retain multipotentiality. And they're able to differentiate into bone if they're induced. They have specific markers, and so they're well recognized by the international community of stem cells. Why fetal mesenchymal stem cells? The idea is we're going to use fetal rather than adult mesenchymal stem cells for this treatment. And that is because they are more osteogenic. So they're more likely to produce bone than adult mesenchymal stem cells. They have a higher calcium deposition. They have a higher alkaline phosphatase expression and higher ectopic bone formation in mice. And a higher differentiative potential, and they're far easier to expand than adult mesenchymal stem cells. So over here, if you look at this slide, this shows alkaline phosphatase activity in human fetal liver mesenchymal stem cells compared to other types of stem cells, including those from adult tissues. And they're more osteogenic than adult MSCs, as you can see here, as I've said, so higher calcium deposition, higher alkaline phosphatase, and more robust osteogenic gene expression. MSCs can form ectopic bone in non-SCID gamma immunodeficient mice, and the mineral volume is higher if you use MSCs than if you use adult MSCs. So preclinical studies in mouse models of osteogenesis imperfecta have shown that transplantation eliminates the perinatal lethality in this animal model. So over to the right-hand side, you can see in black, this is OI mice, and this is in white OI mice that have been treated. So in the humerus and the ulna, there's a reduced rate of fractured bone. The bone strength and thickness and length is higher, and the donor MSCs contributed to the osteoprogenitor population. So these donor MSCs are basically producing daughter cells that contribute to form bone. And there's higher engraftment after prenatal transplantation compared to postnatal transplantation. And 2% of donor cell engraftment produces 20% collagen production. And so in clinical studies, there have been two studies done by Erwin Horwitz in the US, and he took individuals, children that had osteogenesis imperfecta, and did postnatal transplantation using HLA-matched bone marrow and bone marrow MSCs from siblings. And he noticed that there was a reduction in the fracture frequency of about 80%. There was a short-term increase in growth and an increase in total body bone mineral content with new dense bone formation. But this increase was not maintained long-term, and these children actually developed antibodies. And so one of the questions is, if we go fetally, are we more likely to avoid that kind of problem? And that's the underlying plan for the Boost Before trial. There have been 3 cases of OI fetuses transplanted in utero, all done in collaboration with the Karolinska. And this is the first case that was done. So this was a girl in utero who had OI type 3, and she had a transplantation around about 32 weeks done at the Karolinska, an umbilical vein transfusion of fetal liver, first trimester mesenchymal stem cells. And there was evidence of donor cell engraftment in the bone. She followed her own growth curve until 6 years of age. And then following that, she had 4 booster cells with the same donor cells. And these were male donor cells, so it's possible to identify that there was up to 16% engraftment. And she had no adverse reactions and no immune response towards the donor cells, even though they were being given postnatally. She had a reduced fracture frequency after she had the booster, improved ability to walk, and she's had a very good outcome. And there have been a number of other individuals, 3 more fetuses that have been transplanted with fetal MSCs, and a non-transplanted Canadian child with an identical mutation to this girl succumbed at 5 months of age. And so following this data, we, as well, a team led by Cecilia Gotterstrom from the Karolinska, applied to the European Commission for funding for Horizon 2020 for the Boost Before trial. And the overall aim is to develop first trimester derived human fetal liver MSCs as a therapy to treat OI, with the main outcome being safety. So what is the evidence for serious adverse events in the woman, child, and the fetus, with efficacy looking at fractures, time to fractures, growth, and also exploring quality of life and blood and tissue analyses to see, are these cells actually engrafting? We'll be looking at health economics, and we've done some work on the ethical issues. So the Boost Before trial is an open label trial, multiple dose, multi-center phase 1/2. And we're looking at cells that are taken from women who donate, who agree at termination of pregnancy, they agree that their fetal liver cells can be manufactured into a mesenchymal stem cell product produced at the Karolinska. The 3 populations that we're hoping to study, first of all, 15 cases of OI diagnosed prenatally, 15 cases of OI diagnosed postnatally, and then comparing them with historical prospective controls so we can see whether there is any evidence of efficacy. And we would have cases where there was a confirmed molecular diagnosis of OI, only qualitative glycine mutations in the COL1A1 or COL1A2 gene, and children would receive postnatally, they'd have 4 MSc infusions 4 months apart. Prenatally, they'd have 1 infusion prenatally and 3 following as children. And then the follow-up would be 12 months after the last infusion until 10 years after the first infusion. And the outcomes, as I said, primarily safety and tolerability, with other exploratory endpoints looking at quality of life. And so when we were developing the clinical trial, we actually put together a systematic review of in utero stem cell transplantation safety, because we wanted to get the best data that there was out there in terms of what is the risk to the mother, to the fetus of in utero stem cell transplantation. So we found 60 original reports after looking through a large number of references, and they were for 54 in utero stem cell transplantation procedures in 40 fetuses, with a variety of pathologies, mainly hemoglobinopathy, red cell disorders, some immunodeficiencies, some storage disorders, and here are the 2 cases that have been reported of OI. And the median gestational age at delivery of the stem cells was 19 weeks, with 1 to 3 transfusions per fetus. And overall, the acute procedural mortality rate for the fetus was 5.6%. The complication rate for the fetus was 7.4%, with good neonatal survival. And this data was presented as part of our ethical and regulatory submissions to the MHRA and to the Swedish Medicines Agency. What was interesting was that there was very little available about maternal outcomes. There were no adverse events related to stem cell transplantation reported, but we could only find maternal outcomes reported in 14 out of 40 cases for the immediate period, 11 cases for pregnancy and delivery, and nothing about long-term well-being. So I think going forward, it's going to be very important that we have a registry of stem cell transplantation cases and that we follow up and really get good outcome data for the maternal side. But with this data, we got successful regulatory approval in Sweden and in the UK for the trial. So the current progress is that the MSCs have been manufactured and quality tested. That was no mean feat because the stem cells had to be manufactured from new. They had to be tested out in mice to have a look at evidence of teratogenicity, immunogenicity. We've done stakeholder and patient qualitative studies, talking to individuals who have OI about their thoughts of having stem cell transplantation for this condition, and actually very broad support for the whole idea. We've done a review of ethical issues and not identified anything specific. The Swedish Medicines Agency and UK MHRA, we've got regulatory and ethical approval in 2019. And the first postnatal patient was infused in Stockholm in March 2020. Both regulators wanted us to do 5 postnatal patients first before we moved on to prenatal. And so that's what we've been doing in Sweden. 2 postnatal patients have received 3 doses. 3 postnatal patients have received 1 dose. There have been no adverse reactions so far, and we'll be able to start prenatal recruitment once 5 patients have been infused and after a data safety monitoring board review. We have approval for postnatal transplantation in the Netherlands, and in Germany, approval for historical and prospective controls only. But due to time and funding constraints, we've decided to concentrate resources into Sweden. And so at the moment, the only time that postnatal and prenatal is going to be open is in Sweden for the time being, because the trial boost before funding is going to run out probably in the next year and a half. The transplantation procedures. Postnatal, individuals continue on their OI medication, bisphosphonate. It's a peripheral intravenous infusion of the MSCs, usually via an indwelling port. It's the same dose as we give fetally, so 3 × 10⁶ viable MSCs per kilogram body weight, infused over 10 to 15 minutes with 48 hours inpatient monitoring, which was a requirement from both MHRA and the Swedish Medicines Agency. Prenatally, the idea is that we will do an ultrasound-guided injection into the intrahepatic umbilical vein. And the reason for doing that rather than into the placental cord insertion is to try to reduce the risk of infusion going actually into the maternal circulation. So we're really targeting the fetus. 20 gauge needle with a short-acting paralytic and fetal sedation. The MSC is infused over about 1 to 3 minutes. And again, 48 hours of monitoring as an inpatient with CTG, not continuously, but intermittent. But that's one of the requirements from the regulators. The inclusion group for prenatal group, gestational age 16 to 35 plus 6 weeks, obviously couples who are committed to continuing the pregnancy, and we have ultrasound and molecular diagnosis of OI in the fetus. And we have a number of exclusion criteria, including multiple pregnancy, maternal bleeding disorders, inability to comply with the protocol, etc. And probably we'd be aiming to deliver by cesarean section. Referral for those people, we haven't actually opened the prenatal arm yet, but once we do, we'd be really happy to get referrals to us to Sweden for prenatal transplantation. The patients can fly to Sweden, have the transplantation there, and actually fly home and deliver their baby locally. So we have produced a consensus statement around in utero stem cell transplantation clinical trials. The iFetus Society began about 3 or 4 years ago, the International Fetal Transplantation and Immunity Society. And the goals of this group is to find a consensus on target diseases for in utero stem cell transplantation and to bring together the community with the idea probably of developing a registry around this. So if you want to know more about this consensus statement, it's published here in Molecular Therapy in 2020. And this is a really salient comment from this Swiss writer and poet, Philippe Ramy, who's an OI sufferer. And he was having a conversation with Cecilia about the study and was asking lots of questions about it. And he said, I'm sorry to ask you so many questions, but you can imagine, of course, how realistically enthusiastic persons with OI can feel after having been told for so long there is no treatment for them besides bisphosphonates, physiotherapy, and developing a sense of humour and some wiseness. So I think the community is really interested to see the outcome of this trial. We hope that it's going to be effective, but of course we don't know yet, and that's why it's so important to actually trial the treatment. So just to summarise, in utero stem cell therapy for OI is a coming of age. There is tantalising evidence of safety and efficacy from the first case reports. We have regulatory and ethical approvals. We will start the prenatal arm once the DSMB have reviewed the data from the postnatal patients. And if it's successful, then we could test out for other skeletal dysplasias as well. But it will be important in any kind of in utero stem cell work to have our ongoing registry of cases, particularly to look at maternal outcomes. So it just leaves me to thank everybody who's involved, particularly Cecilia, all the teams at the various centres, including LUMC, and it's been great to work with everybody, and I'm very happy to take some questions.
And I thank you very much for this very interesting presentation. There already are 2 questions in the chat, and I'll start with the first one from Melanie de Gier, and she asked, has the DNA methylation profile of these fetal MSCs been investigated?
I don't know that it has, no. We certainly are testing them out for OI. So we had decided that any of the fetal MSCs that would be used as a drug product would be tested out to make sure they didn't have OI. But I don't believe that we've tested out the methylation profile.
Okay, thank you for that answer. And then there's a second question by Umber Argawal. How to account for the phenotypic variability in presentation of OI type 3 for the efficacy of stem cell transplantations? Are only severe cases being transfused?
Yes, I mean it is. When we have cases, we basically pull together all the experts, either postnatal OI experts or the fetal experts, to make a decision about whether to proceed. And the cases do have to be severe. Of course, in utero, it's quite difficult. It can be quite difficult to tell. So I think that's why we have groups from 4 different countries who are a panel who make a decision about which are the severe cases that would be eligible for the trial.
Okay, thank you very much. I still see a raised hand from Martin Walker, but I think it was regarding the first presenter. Somebody else has a question? No, okay. Then I would like to thank Anna for the very interesting presentation. We will have a really short break so we can start in time again. Now it's exactly in the Netherlands, it's 5 o'clock. For everybody else, can that be different? But I would say just a break of 5 minutes. So grab a cup of coffee or a glass of wine or whatever you prefer for a short toilet break, and then we'll be back in 5 minutes.
Hey, help! Kom met al die pings. Ja, wat heel irritant, hè? Ja. Wil je een correctie? Nee, dankjewel. Oh, dank je. Gaat goed? Jo, met jou. Ja. Goed zo.
Frans, hier Michael Kars uit Utrecht. Je
Hoi,
microfoon staat aan.
Mijn microfoon, alles staat aan, oké.
Wel gezellig hoor.
Ja.
Welcome back, everybody. I'm honored to announce the next speaker, Tippi Mackenzie. She's a professor and pediatric fetal surgeon working at the University of California in San Francisco. She leads a translational research lab examining the unique biology between the mother and her fetus. And the Mackenzie group focused on fetal therapies, including stem cell transplantation, enzyme replacement therapy, and gene therapy. Her group was also the first to give a fetal stem cell transplantation. Currently, we treat the first thalassemia major patient in the Netherlands with close contact with the Mackenzie group. So we are very happy with that. We support our collaboration and sharing data for their international registry to improve outcome for these patients. And we are honored she will present today on fetal stem cell therapy and enzyme replacement therapy. Thank you, Tippi. Can you maybe share your screen? I will unshare.
Thank you so much. It's really an honor to present to everybody today. Here we go. Thank you so much. These are my disclosures. And yeah, so we're all gathered to talk about innovations in fetal surgery, right? Extending from work with spina bifida and now beautiful work being done in fetoscopic spina bifida repair and other fetoscopic interventions. A lot of us do catheter-based interventions and this umbilical vein infusions. It was nice to hear the new clinical trial for the IVIG, and we'll be participating in that. And hopefully I'll convince you that some of the stem cell and enzyme replacement and gene therapy work will be other occasions to use this very versatile technique of accessing the fetal circulation through the umbilical vein. So it's an incredible time to be thinking about fetal therapy for single gene disorders when you think about the convergence of all these technologies happening in medicine right now, the ability to do rapid genetic diagnosis, often with whole exome or whole genome sequencing of the fetus with results back interpreted in a matter of days. Fetal surgery techniques are of course expanding throughout the world, and the gene therapy and genome editing fields are exploding. So this gives us a number of different techniques in our armamentarium, such as using stem cell transplantation, enzyme replacement therapy, or gene therapy or genome editing. And these are some of the single gene disorders that our group and those around the world are thinking about: thalassemias, lysosomal storage disorders, spinal muscular atrophy, et cetera. And as Anna alluded to, some of the principles why we would want to treat the fetus before birth instead of waiting until after birth are that the fetus can be tolerized to new proteins or antigens. You can protect the brain before the blood-brain barrier has formed, and you can access stem cells during their migration to their final niches. So for example, hematopoietic stem cells are very accessible in the fetal liver before they move on to the bone marrow. So this is the pipeline of the molecular fetal therapies we're either doing or contemplating at UCSF. So the red outline are enrolling clinical trials. So for stem cell transplantation, we're enrolling for patients with alpha thalassemia major, and we're in discussions with the FDA regarding expanding the indications to other hemoglobinopathies based on the safety we've seen so far. And in the future, we'd like to treat patients who have fetal renal failure. And we're also just launching an in utero enzyme replacement therapy clinical trial for lysosomal storage disorders, and also actively in discussions with the FDA and ethics expert regarding prenatal gene therapy for other reasonable disorders. So alpha thalassemia major, why are we thinking about this? It's a fascinating disease that's been mainly ignored by our medical community. So a little bit of background, as you all know, as adults, we have a hemoglobin chain that has 2 alpha and 2 beta chains, but as fetuses, we had 2 alpha and 2 gamma chains. So if you're a fetus where all 4 of the alpha genes are mutated, you make these gamma tetramers that really don't release oxygen when they're in the tissues. So the fetuses get very hypoxic. And of course, the ultrasound manifestation of that is hydrops, where you see fluid in multiple compartments. And these fetuses, you know, if the parents seek fetal therapy, they can already get a fetal transfusion. So there's already access to the umbilical vein. So we thought this was a good ethical rationale to give hematopoietic stem cells at the same time. And as you know, in parts of the world, such as China or Southeast Asia, there's a very high carrier rate. But still, throughout the world, most patients are counseled to terminate due to concern for neurologic outcomes. So one of the things we've done in conjunction with our clinical trial of stem cell transplants is to start an international registry to really understand patient and provider attitudes regarding fetal therapy or termination and look at neurologic outcomes of fetuses who had adequate transfusions. And so what we've done is to compare patients who had 2 or more transfusions before delivery to those patients. And most of these are those that are born spontaneously without having any fetal hydrops. So they came to diagnosis after birth. And you can see that the gestational age at the time of birth is higher if you had 2 or more transfusions in utero. And of course, then the hospital stay, this is the length of the neonatal ICU stay for patients who had more than 2 in utero transfusions is much shorter compared to those who did not. And then my colleagues Marisa Schwab and Billy Leognoli at UCSF called all of these families and did a neurological outcome testing, which is the Vineland score. And you can see that there's a very nice inverse correlation between the Vineland percentile and the gestational age at the first IUT, really showing this logical concept that if you start the IUTs early in gestation and you're actively treating the hypoxia and the hydrops, that you'll end up with normal neurologic outcomes. The 2 red dots there are the clinical trial patients that I'll say more about later. And so we think it's reasonable and quite ethical to offer fetal therapy to fetuses with alpha thalassemia major. So the alpha thalassemia major patients after birth are quite similar to those with beta thalassemia major in that they have 2 main possibilities for treatment. They can either get chronic transfusions, which they get every 3 weeks. Those can be complicated by iron overload, for which they get chelation therapy, and you can have toxicity from the chelation therapy. So definitely a chronic disease. Or they can have a stem cell transplant, which is a definitive cure, but comes with an upfront mortality of at least 10%. It can be difficult to find a suitable donor after birth. And because of the conditioning that you have to do to make space in the bone marrow, it can be quite toxic. You can have graft versus host disease, et cetera. So we think that doing a stem cell transplantation before birth can decrease the burden of disease. And for this, and we weren't the first to think of this, people have done in utero stem cell transplants, as Anna showed that series before. I think our contribution was to really think about who is the best source of stem cells. And here we've thought about, can we harness the natural piece of biology that occurs during pregnancy? And we all know that there are fetal cells in the mother that form the basis of prenatal genetic testing, non-invasive testing. And there are also maternal cells in the fetus. And in 2008 and 2012, Jeff Mould, who's now at the Karolinska, was then at UCSF and Mike McCune's lab, had a series of beautiful papers where he showed that fetal T cells, when they encounter these maternal cells in their circulation, have a very unique biology in that they develop not into these effector T cells that would then kill off those cells, but actually to regulatory T cells that develop an active tolerance against these maternal antigens. And that this tolerance of the fetus for the mother is actually an active concept, and it's a very critical part of a healthy pregnancy. And so from this, we think it follows that if you want, from this, actually, we then had a mouse study that was led by one of my colleagues, Amar Nijigal and Dr. Tong, where we showed in the mouse model that if you transplant any other cells, the maternal cells that are in the fetus actually mediate rejection of third-party donor cells in mice. And so we think some of the lack of successes in the previous human transplants that have been done were perhaps because maternal cells were not always used. It's been shown now in our field, in Dr. Flake's lab and other labs who work on this, that you have to have a very high dose of cells because you're not doing any conditioning, and you have to put those cells into the systemic circulation. You can't do an intraperitoneal injection. And so from all this, it follows that, in the next clinical trial of in utero transplantation, we should be transplanting maternal cells. And because we're not doing any conditioning in the fetus, this is really a part of a two-step protocol. We're not really hoping or dreaming of a one-shot cure with the in utero transplant. So you do the in utero transplant so that you can sustain this tolerance, you can sustain the regulatory T cells, and then you can do a postnatal booster transplant to improve the chimerism to cure the disease, because postnatally you can give a little bit of conditioning. This was shown very nicely by Bill Paranto, who's also a CHOP, in mice who have sickle cell disease or thalassemia. And you can see initially, these are the mice that had the initial in utero transplant. They were tolerant, therefore they could get a tiny booster and achieve high levels of chimerism. And so we think that this is going to be, our trial is going to be a two-step protocol. So that brings us to our phase 1 clinical trial for alpha thalassemia major, where we are transplanting maternal bone marrow cells, so CD34 cells that we get from a bone marrow harvest, and we're adding 1% T cells back. We're doing this between 18 to 26 weeks through the umbilical vein. Before 18 weeks, we don't think it's safe to access the umbilical vein, and we haven't wanted to do, well, the FDA hasn't let us do intracardiac injections, and the diagnosis actually happens around 18 weeks mostly. And after 26 weeks, we think there probably won't be an immune advantage, and we're continuing the transfusions every 3 weeks. So fetuses get an in utero transfusion at the same time as their single stem cell transplant. Our goal has been to enroll 10 patients over 3 to 5 years, and it's a phase 1 trial, so the endpoints are mainly safety and feasibility. And so we've had grant funding for this since 2007, and we are recruiting patients for enrollment and open for international patients as well. So here's some mechanics of how this happens. So mom has a spinal anesthesia, and we do an old-fashioned bone marrow harvest. We have not wanted to mobilize peripheral stem cells during pregnancy, so it's a sacral bone marrow harvest. And then it's a routine processing using a Clinimax where we isolate the CD34 cells. Our pediatric bone marrow transplant team does this. And then we do endotoxin testing, et cetera. And then they're infused using ultrasound guidance and using exactly the same setup that anybody would use for an in utero transfusion with the spinal needle, ultrasound guidance. And this is after a full day's processing. It's a 2 milliliter slurry of a very high concentration of stem cells, because again, we're not doing any conditioning. So we've transplanted 3 patients so far. The third one is still in utero and just had their 4th transfusion on Tuesday. The first 2 presented with hydrops. The third one actually was pre-hydropic and has been making zeta globin, the Portland 2, which we think is super interesting because they presented later. All of them have improved with the in utero transfusions. We were able to get, this is part of the feasibility of the trial. Can we have a very high dose of stem cells from a single bone marrow harvest? And we've shown that we can do that. And each patient has transfusions every 2 to 3 weeks afterwards. And in terms of safety and efficacy, I'll just present the first 2 patients, of course, because they are born and have finished the 1-year follow-up. We haven't had any issues with the maternal bone marrow harvest. No preterm labor because the hydrops resolves completely. Short NICU stay, 2 to 3 weeks in each of those patients. And both, as I showed you, have had normal neurologic testing at 1 year. Again, reiterating that if you do the transfusions and you treat the hydrops, these children can have excellent outcomes, no preterm labor, and good neurologic testing. And in terms of efficacy, of course, we have detectable but low levels of engraftment because we haven't done any conditioning. But we have seen tolerance to the maternal antigens that sustained for the whole year after the transplant in our first patient that we're very excited about. And we've been speaking to them about a booster transplant. And we have noticed as part of this work, meeting so many patients around the world who maybe chose not to participate in the clinical trial, but are in our registry. And we're understanding that this is actually a public health, and at least in the United States, a health equities issue because patients are not given the choice for fetal therapy. And so we've recently hosted an international meeting to talk about optimal prenatal and postnatal protocols for alpha thalassemia major. And all of this is free online. So if any of you want to listen to some of the lectures, it was a 2-day meeting, please let me know and I can give you the website. We've also made a short documentary that features a number of our families, and the title is Surviving with Joy, which is what we understand that these families are doing. And so these are some of the pictures that they've shared with us. So I'm going to switch gears now and talk about our next clinical trial, which is prenatal therapy for lysosomal storage disorders. As you know, these are a number of related genetic diseases with a deficiency in a single critical lysosomal enzyme, and they can be treated with either recombinant enzyme therapy or stem cell transplantation. But both of these come with issues. Patients can have immune responses to the recombinant enzyme because their body sees it as foreign, and the stem cell transplant, of course, comes with all the host of problems that we just covered. And so the rationale for prenatal therapy, one is to prevent in utero demise. Those with MPS 7 especially can present with hydrops and sometimes don't make it to term. We want to induce tolerance to the missing enzyme. We want to deliver the enzyme to the brain before the blood-brain barrier forms, and of course, prevent organ damage. So we did this initially in a mouse study that I won't go over in much detail because it's published, but the mice with MPS 7, when we gave them the enzyme in utero, did very well. We improved survival, improved all the storage disease in the liver and spleen and kidneys, improved bone length. We saw that the enzyme penetrates into the brain. And most importantly, which is the figure I'm showing here from the paper, we induced tolerance. And the way that we did that was we gave multiple doses of the enzyme. And in one of the doses, we gave a Freund's adjuvant, which really tries to sensitize the animal. And then we did an ELISA for antibodies against the enzyme. And here you can see these IgG antibodies against the enzyme. You see them in the control mice that never saw any in utero or neonatal therapy. You see a little bit of tolerance to the neonatal mice, but the in utero treated animals did not develop any antibodies except for this one right here. And so based on this, and actually after being referred a patient with MPS 7, we decided to put a team together to develop a safe and ethical protocol for in utero enzyme replacement therapy. I have to say this is, compared to the technical skills that are necessary for all the, open fetal surgeries or fetoscopic fetal surgeries that we all do, this seems like low-hanging fruit. So I've been really surprised to see that this hasn't been done in our field. But I'm excited that, once we put this trial together, we can collaborate with many colleagues internationally. We surveyed the MPS Society, and I'll show you the data from that survey about their willingness to participate. And our IND was approved, and we're launching a phase 1 trial now. And so this trial will be, it's an umbrella IND approval that we got for a number of disorders, which was interesting that the FDA granted it because they recognized that these are quite related disorders. And so it didn't make sense to get separate INDs. And so these are MPS 1, MPS 2, 4A, 6 and 7, as well as the infantile version of Pompe disease, neuronopathic Gaucher, which of course is devastating but super rare, and Wolman. So the diagnosis is going to be made by either CVS or amniocentesis. We think a lot of these are going to be repeat families who've already had an affected pregnancy. And then the enzyme replacement therapy is going to be given just through the umbilical vein, just like you would for an IUT, every 2 to 4 weeks because of the half-life of the enzyme. And then the postnatal care is going to be standard with yearly follow-ups. So again, it's a phase 1 trial. So the primary objectives are safety and feasibility. And the secondary objectives are efficacy. So is there decreased GAGs, which are the toxic metabolites that develop? Is there tolerance to the enzyme replacement therapy, which some of these patients, especially those with infantile onset Pompe, need to go on pretty impressive immunosuppressive drugs shortly after birth? And then what are the long-term outcomes? So the risks and benefits, the potential benefits I've talked about, all of these that are listed here. The main risk, of course, is the risk of the in utero injection protocol, as you know. You can have preterm delivery or bleeding. Hopefully the risk is less than 5%, but for some of these patients who don't have alpha thal major and who of course don't otherwise need an in utero intervention, That's very important to think about, which is why we reviewed our center's data with the in utero transfusions to make sure that we're offering a safe protocol. There's a potential of an allergic reaction, which we're going to test for. We don't really think it's going to happen because the fetus should be tolerized and the mother should really not see a high dose of the enzyme, and she should already be tolerant because she's only a carrier. So in terms of the feasibility, I think the most important thing is, can we identify affected fetuses? All of these are super rare, as you know. For alpha thalassemia major, we have seen an increase in referrals after opening the trial. And for lysosomal storage diseases, as I mentioned, we think it's mostly going to be families with a prior affected pregnancy because we don't currently have a carrier screening protocol for these disorders. And as you know, we don't have carrier screening because there's nothing different you would do in the pregnancy. But if you have a viable fetal therapy during the pregnancy, we think that that might change the equation for recommending screening or for families opting to have carrier screening. So we've engaged the patient community both in the United States and in Canada, Europe, and Brazil now. These are the results so far compiled for American patients, where we ask them 3 simple questions. These are parents of patients with current children who have lysosomal storage disorders. So would you terminate a future affected pregnancy? And most of them said unlikely. Would you choose fetal enzyme replacement therapy if it were an established therapy? Most of them said they would be likely. And even when framed as, would you enroll in a phase 1 clinical trial for fetal therapy? Again, most of them said likely. And we've gotten some really, just interesting comments and Facebook posts, et cetera, about patients thinking that this might be something that they would welcome. So a lot of regulatory considerations, of course, when you're thinking about new fetal therapies. The FDA has told us that they would only approve a medicine that's FDA approved in the postnatal setting first. So all these enzymes are FDA approved postnatally. There has to be a prospect of benefit when you're dealing with fetal or even pediatric patients, even for a phase 1 trial. So you have to have really good preclinical data of the prospect of benefit. And we've had a lot of discussions about doing fetal therapy for diseases that are not embryonic lethal. And we now have approval from the FDA. And I think we were really helped by the whole field of spina bifida and doing sometimes open fetal surgery for a disease that's not embryonic lethal. So in terms of the summary and next steps, we think that fetal transfusions can result in excellent outcomes in alpha thalassemia major, and we're continuing the recruitment for our stem cell transplantation clinical trial, as well as launching our new trial of in utero enzyme replacement therapy for lysosomal storage disorders. And we are doing some preclinical studies for in utero gene therapy now in hopes for starting a clinical trial in that. So please do contact me if you have a patient with alpha thalassemia or lysosomal storage disease for inclusion in our international registry or the clinical trials. And we do have funding, thankfully, for international patients. So I'm here on behalf of an incredible team of people that I represent at UCSF. On the thalassemia side, I'm very lucky to work with very established hematologists such as Elliot Wachinski. And on the enzyme replacement therapy side, with Paul Harmatz, who does a lot of the postnatal clinical trials, as well as acknowledging my lab, who have done a lot of the preclinical studies, and other collaborators. And so thank you so much. I'll be happy to take any questions.
Dear Tippi, thank you very much for your very interesting presentation. And as you know, we're very happy to join to collaborate the data for your registry. I would like to, I thought I saw a raised hand, and I think it was by Frans Klumper. Was there something that you would like to ask, Tippi, or?
No, it was not a raised hand, it was applauding hands. Thank you for your presentation, Tippi.
Thank you so much. Thank you so much. Yes, and I'm very excited to collaborate with all of you because the stem cell trial we're doing at UCSF, because it's challenging to do the initial stem cell harvest and the bone marrow processing, in the timing of pregnancy. But I think the enzyme replacement clinical trial, especially with COVID, it just makes a lot of sense to work together. And so we are setting up an international consortium so that, as anybody around the world diagnoses a fetus with a lysosomal storage disorder, we can share our protocol and work together for an international collaborative clinical trial. I think, especially if we're recruiting families who already have an affected child and therefore a special needs child at home, it's going to be challenging for them to travel. So we'd love to work together with all of you.
Okay, thank you. There's one question coming from Mabli. For international patient, is the procedure done in the USA or the country of origin?
So yes, for the stem cell transplantation trial, that procedure has to be done in the United States because it's the FDA approval we got is literally for taking the maternal bone marrow and processing those cells to put into a fetus. And so I think we still need some safety data for that before thoroughly publishing that protocol and disseminating around the world. For the enzyme replacement therapy, we have made a clinical protocol that we can share as part of a collaboration. And yeah, we'd love to work together with colleagues around the world to launch that because, especially during COVID, it doesn't make a lot of sense for people to travel to San Francisco to get a recombinant enzyme infusion.
Thank you. And I think the next question is, what are the resources available for those patients? So because you said there is funding for treating international patients, is that also for traveling or is it only for the treatment in the USA?
Yes. So for the stem cell transplantation trial, we have very generous clinical trial funding as well as philanthropic support. So that covers the entire journey of the patient. They can even stay in San Francisco for the duration of the pregnancy, which is what we're doing for our third patient, so that they don't have to travel back and forth during COVID. And so all of the travel costs, the housing costs, and even the food, et cetera, are covered during their stay in San Francisco.
Wow, that's very generous. Any other questions? What about visa?
So the visa, we have an international office who will work with the patients to get the visa. So to be honest, we have not yet enrolled in international patients. So I'm hoping that that's not going to be too much of a problem between the time of diagnosis and the final window of inclusion for the stem cell trial is 26 weeks. But we have an international office who knows about the trial and who are prepared to sort of jump in and help with visa stuff. And beyond the clinical trial, as we've spoken before, I think just inclusion in the international registry so that we can understand the presentation and the management of these patients. We're finding really interesting differences, for example, in the genotype-phenotype correlation. If somebody has an intact zeta globin gene, they tend to present later and potentially have different needs during the pregnancy. So because these are all such rare diseases for any one center to know about, I think it's really important for us to work together to understand how best to treat these families.
Oh, thank you very much, Tippi. I agree on that. I think it's very important. That's why we was one of the reasons why we had this LUMC Global event today, that it's very important that we collaborate nationally and internationally. So thank you very much for stressing that out. And before I'm going to present our last speaker, we also like to stress out that please stay tuned because the presentation of Monique Haak will start, but afterwards we will also have a bonus. So please all join. And because there will be a bonus afterwards, I would already like to thank everybody who joined us today. We had a lot of participants, 170 participants joining nationally and internationally. So thank you very much for that. And we will also welcome you to send us comments or questions to the email address fetaletherapy@lumc.nl as we showed before. And I also would like to give a special thanks to Owen Hennekamp and Evelien Haak. They're from the Global LUMC for helping organizing this event. And of course, I would like to thank Ivanka Becker. She helped to organize this event as well and did a lot of extras to make this all go smooth. And I would like to thank Lisanne Tollenaar. She's always helping us with beautiful illustrations. And of course, of all speakers who made this an event, a platform for the national and international collaboration. So now I'm going to announce our last speaker, which is our beloved colleague Monique Haak. She's specialized in both fetal therapy and fetal cardiology. And her expertise is on fetal cardiology is of utmost importance of fetuses with congenital heart defects, but also fetuses who acquired a heart defect during pregnancy. And for this reason, she's able to combine her expertise, for example, for congenital malformations such as aortic stenosis or acquired malformations, as we can see them in complicated monochorionic twins. And so she also combines the epigenetics with cardiac function in the twin life study. And she lately received a big grant to explore the benefits from the possible introduction of the 13 weeks anomaly scan in the Netherlands on a national basis. But today she will present on the cardiac interventions. So Monique, the floor is yours.
Thank you very much, Joanna and Femke. First, I will share the screen. Here I am. Yes, thank you very much for the invitation to talk on this International Fetal Surgery Symposium. And the last topic is concerning fetal aortic valvuloplasty. And as the previous speakers also did, is that I want to begin with the end stage of the disease that we really want to prevent. And what we want to prevent with aortic valvuloplasty is hypoplastic left heart syndrome. And I think it almost doesn't need any introduction that this is one of the most severe congenital heart defects concerning a very small, too small left ventricle, aortic valve stenosis, sometimes atresia, and hypoplastic aortic root, and an hypoplastic mitral valve in most cases as well at birth. This hypoplastic left heart syndrome carries a high mortality in the first years of life. And even if the baby is successfully operated with a palliative strategy, then still these children face an impressive morbidity with, for instance, reduced ability to exercise, liver cirrhosis, problems with the intestine, and if they reach adulthood, they have a reduced life expectancy with the start of cardiac failure early in adulthood. So it is a severe congenital heart disease with, in my opinion, a grim outlook. So already for more than 30 years, people want to prevent this end stage of a disease. However, hypoplastic left heart syndrome has 4 subtypes. And I think that is always important to realize. It can start very early in pregnancy with aortic atresia, and then early in pregnancy, even already in the beginning of the 2nd trimester or the end of the 1st trimester, the left ventricle is already very small and maldeveloped. But the end stage hypoplastic left heart syndrome also can be because of progressive aortic stenosis in the course of the pregnancy, with also a good mitral valve. The both phenotypes I will show in the following slides. This is a child with combined mitral valve and aortic valve stenosis at 20 weeks gestational age. And here you can already see the normally sized right ventricle with a good tricuspid valve and a small left ventricle with shortening, and that is very important, shortening of the left ventricle. If the ventricle at 20 weeks is like this, and fetal surgery will not help. Again here, the same fetus, hardly any blood crosses the mitral valve. All the blood is directed to the right ventricle. And if we see the sagittal views, then you see that the aortic arch is very much narrowed and shows retrograde flow. Retrograde flow is one of the key features of hypoplastic left heart syndrome. This is the other phenotype, and here you see a totally different picture. In this picture, we have an enlarged left ventricle. Again, I show you cases around 20 weeks. An enlarged left ventricle, which very much decreased contractility, especially if you compare it to the right side here. The right ventricle contracts normally, and the left ventricle is almost standing still. A small rim of fibroelastosis. And if you look here, and that is always with referrals, referring physicians think that the mitral valve is sick also, but the pressure, the intracardiac, intraventricular pressure here is very high, therefore hardly any blood is visible with color Doppler if you compare with the right side. Also here, retrograde flow, reversed flow in the aortic arch, which is one of the key features. If progressive aortic stenosis is apparent, then we can perform a valvuloplasty of the aortic valve. But because those procedures are risky, we have to have certainty that these cases develop into hypoplastic left heart syndrome and that there is a potential benefit of the intervention. To be sure about that, there are more or less three main features that have to be present. And the first one is that the valvular aortic stenosis is the dominant cardiac anomaly. The second feature is that we have to do with an evolving hypoplastic left heart syndrome, and there are several criteria in which the case has to be met. Thirdly, of course, there has to be any potential that there will be reversal of the phenotype. And if you look at all the criteria that are used, that are all difficult ways to say that the left ventricle has to be enlarged at the moment of the valvuloplasty. If we look to the global results, then this is the first publication I want to show you. It is a publication already some years old. It's from the group of Wayne Toretsky. They published on the first 100 procedures that they performed. And if you look to the figures, then you see that the success rate is around 77%. Fetal demise, I already said before that these procedures are risky. Fetal demise at procedure is around 11%. And if those babies reach a biventricular heart from birth onwards, they still face large surgery in the first year of life. 40% of these children have a ROS procedure, which is also major cardiac surgery, and 60% have mitral valve repair. If you read those papers very thoroughly, you also see, and that is still, that illustrates that still the correct selection of these cases is difficult, that 3 cases reaches a biventricular heart in the group that did not have a successful valvuloplasty. So still the selection of the fetuses who will benefit from a fetal procedure is still difficult. Another paper, and I think this is important because the previous paper, that is a single center report, and Dick already showed you in his presentation that single center reports are always better than the real world experience. So this is the real world experience. This is the IFCARE registry. in which all centers, or not all, but a lot of centers who perform fetal aortic valvuloplasty register their cases. This paper was published in 2015, and here you see that the success rate, the technical success, is again around 80%. 20% were not successful, 12% demise during fetal surgery, which was even higher in the group that was not successful, and that's of course understandable. Things were difficult, and the surgeons took, I think, a bigger risk. And if you look at the biventricular outcome at discharge, then you see that 34% of the fetuses reached biventricular outcome if you calculate from the technical success onwards, or 42 if you subtract the fetuses that showed demise. I want to point out that also here, 4 cases additionally performed termination of pregnancy, and that is important to keep in mind for the following slides. Hello, very welcome. I think it's always nice to show some cases. So here we will show our Leiden experience. This is a lady with not a very favorable BMI. Here is the introduction of the needle in the heart. The waiting time for an optimal fetal position is very important, because if you do not have a good fetal position, there is not a lot you can adapt. So that is one of the most difficult parts for surgeons, just to wait until the baby is in a good position. Then the next movie clip, you see the advancement of the guide wire through the aortic valve. And here, because the needle is in a very good position, and that guide wire is very flexible, so that doesn't go around corners. And here it goes very nicely through the aortic valve. Here's the insufflation. And if you look at the end of the clip, you see that the bradycardia is visible. And that is, although it's always a bit impressive, but it is a good sign, because the balloon is blocking the coronary arteries, and that is why the heart is slowing down. This is shortly after removal of the needle, and then you see one of the complications here. Here you see the heart, and this is the pericardial space, and it is filling up with blood, and that is one of the problems of this procedure. And you see here an immediately very deep bradycardia, and that is always something you want to remove very quickly. You see here some movement. That is my finger already becoming ready to introduce a needle to empty the pericardial space. That we see on the next slide. It is a different fetus, also in a very severe bradycardia after the procedure. The needle is inserted into the pericardial space, and we are aspirating the blood in the pericardial space. And after a successful drainage, you see here the heart rate already in a normal heart rate. But still, even after a good dilatation, the myocardial contraction is still, that needs some time to recover. One of the main parameters to define a procedure as successful is forward flow across the aortic valve. And that is visible here in this clip. This is a blue signal. I have to admit that the frequency, the speed is still low, but this could not be visualized before the intervention. A second parameter of a successful dilatation is aortic insufficiency, because then we know that the aortic valve is opened well. And here, this is the same fetus. This fetus before the procedure had reversed aortic arch flow, and here you see that it is normal, a normal direction of the flow in the aortic arch. So we are a small country, but we do have a national referral system, and the aortic valvuloplasty was started around 10 years ago. From that period onwards, we have received many more referrals to see if the fetus was eligible for this procedure. And there were more eligible cases, but a vast amount of women decide to terminate and not to want this procedure. But from the 8 women who wanted the procedure, who consented with the procedure, we had a success rate of a technical success rate of around 75%. We had 2 failures, both were a perforation of the mitral valve, and this figure is very comparable, very similar to the international reports. We had one case who was one of our first, who is doing very well 8 years after the procedure, but did have a Ross procedure at the end of his first life. We had one child that had a successful valvuloplasty, but afterwards was diagnosed with not a large enough left ventricle, so had to have palliative Fontan repair, and that was a very difficult social situation. And those parents eventually chose to have comfort care, and that child died at the age of 4 months. There was one fetus who had a successful recovery of the left side of the heart. So the heart went very well, but developed progressive hydrops during pregnancy. That was already an older case in which we did not, at that stage, we did not do exome sequencing in pregnancy, and that baby died because of hydrops, but without left hypoplastic heart syndrome. And what I want to talk about is the 3 cases in which termination of pregnancy was requested later on. All those 3 cases I have to say, all our cases are treated around 21 weeks of pregnancy. And in our country, the legal limit for termination is 24. So in the following weeks after the procedure, these fetuses did not show any recovery of the left heart, although the aortic valve was patent, was opened. I want to show some post-mortem examinations. This is work of Fleur Zwanenburg. Thank you very much, Fleur, for these nice pictures. This is a case with a technical successful fetal aortic valvuloplasty. And this is a coloring which in red is fibrosis. And this part is enlarged. And here you see that the fibrosis is very extensively in the myocardium. And to compare, this is normal myocardium. And I see my time is already, the time is going fast, so I will go fast. If we enlarge more, then we see the alignment of the sarcomeres are very, very disturbed with all those bright cells with nuclei that are purple. And in normal myocardial tissue, the sarcomeres are aligned like stripes. So even the aortic valve was open, this heart showed microscopy of an hypoplastic left heart syndrome. So this myocard was, I think, too sick to recover. Here another case which did not receive a valvuloplasty but decided to terminate before that. This case had critical aortic stenosis, which at that stage, at 20 weeks, was not that severe to meet the criteria for a fetal procedure. But I think if this woman would have prolonged the pregnancy, maybe she would have met the criteria for aortic valvuloplasty at, let's say, 26, 27, 28 weeks, because the aortic valve, as you can see, was very thickened with very high velocities across this valve. And here you see that this case, again 20 weeks, the fibrosis is very mild and the myocardium is not really normal, but less sick than the previous case. Also, the microscopy was, the alignment was nicer and not that sick compared to the previous case. So questioning our results, and although it is a very small series, there are some thoughts. And one of the thoughts is, if we follow up between 21 and 24 weeks, is the recovery time for the myocardium, is that time long enough? Do we wait long enough? And of course, we cannot wait longer because of the legal limits of termination in our country. Do our results have something, can they be explained by the timing of occurrence of the critical stenosis? Or to put it in other words, if we see such an enlarged left ventricle at 18, 19, 20 weeks, is that phenotype then maybe different from those that at 20 weeks have still more or less a normal four-chamber view and show that ultrasonographic features at 27 weeks? Because the international series, they usually have a mean operating gestational age at 25, 26, 27 weeks. So that is really later in pregnancy. Do we expand the balloon enough? I think the answer to that is yes, because we expand 1.2 like the other published series. And finally, it is only 8. Do we need more experience? Is that the reason that those hearts did not recover? I don't know. I think technically we do it exactly like published in literature, but of course it can be a learning curve effect. Then my final slide, because I really think that timing is also an issue, and that when the babies get larger, we also have cases of aortic stenosis that are still not eligible, or later in pregnancy, almost eligible, but then the aortic valve is too wide to have a proper balloon that may pass the needle. So we are working together with a very bright young student, Eline Gigenaert from the TU Delft, to improve the balloon, because now we use the balloon that is used for PTCA, and that has other requests than the requests for balloon for fetal procedures. So we want to make it thinner. We want to have it visible on ultrasound. We want a larger balloon, and we want easier retraction. And to work with a student from a technical university that gives all new possibilities. And we are working very, very nicely to create a dedicated fetal balloon. I think we are nicely in time to have questions. Femke and Johan, are there questions?
Dear Monique, thank you very much for presenting. There was only one short question. Would you recommend to remove the fetus before or after maternal anesthesia? And then I think we should continue.
Remove the fetus before anesthesia?
Yeah, I think before we paralyze the patient or paralyze the fetus, whether you would move the fetus first or afterwards?
Oh, I think that question concerns positioning of the fetus.
Yes, that's what I assume.
Yeah, in our center, we do not give the mother anesthesia. We only give her a little bit of midazolam to keep her quiet, but we do not give full anesthesia. And I think having done 6 of these procedures now, I think it's not necessary. We do give the baby atracurium to keep the baby still, and also fentanyl for pain relief for the baby, for the fetus. But no, we perform those procedures without any maternal anesthesia, and that is very well possible.
Thank you very much, Monique. You can proceed.
Okay, thank you very much. At the end of this talk, I want to take some time for saying goodbye to a very special colleague of mine. Also on behalf of our whole Leiden fetal medicine team. Dick has stopped working almost a year ago to enjoy life even more. We planned a big party with a symposium, but due to the COVID pandemic, this had to be cancelled. But some parts of this day cannot be postponed anymore. And therefore we decided, against Dick's own will, to end this global webinar with an official thank you, Dick. Dick has worked as a fetal medicine specialist for over 20 years in Leiden, and before that as a PhD student and an ultrasonographer and a resident. In these years, he has meant a lot for fetal medicine, locally for the Leiden University Medical Center, nationally, but also internationally as well. A few examples. He is one of the first to investigate on the use of Doppler in the monitoring of fetal anemia. He introduced science in a field that at that time was developed by experiments and trial and error. He introduced the Solomon technique by an RCT for the treatment of TTS. And RCTs are unique and very difficult in fetal medicine. He was an early adapter of NIPT and helped NIPT being introduced as the first-tier test in the Netherlands. And if RCTs are no possibility anymore because everybody believes in it, like in aortic ballooning, he used other options to enlarge knowledge on the topic, and started together with Anita Moon-Grady the international IFCARE registry. As a practical obstetrician as well, he has had the insight that practical courses are important, and together with Annemiek Middeldorp and others, introduced the Mood course in the Netherlands. And finally, together with Enrico Lopriore, he has described TAPS as an entity and a serious complication in monochorionic twins. Besides all these professional achievements, we share very good memories, of which some I want to share with you. Dick has the habit to travel all over the world frequently and to dine wherever possible. The bottles of wine were always of very, very good quality and the bills expensive. But I have to admit, the PhD students were always kept free. Also, partying was a big hobby of Dick, in which he was not afraid to dress up nicely or to play guitar with very, very long solos, or to hang out with the most lovely ladies in town. I want to end with a few wise sayings of Dick, in which he always wanted to teach the younger colleagues. The first is, when he wanted to do something which was at least debatable, you can always say sorry afterwards. when we have had some setbacks, to cheer you up, he would say, shit happens. In the morning, life is too short to drink bad coffee, which even resulted in a very professional coffee machine at our staff offices, in which the fresh milk would grow nicely green cultures. For the residents, if Dick did not want to see a patient himself, I have a very, very interesting case for you. And finally, for me personally, the most important wisdoms of Dick, because we as fetal surgeons also have to endure still too often some losses. Dick's message was to remember the ones you can save. Some you win, some you lose. Dick, thank you very much. And I want to invite somebody special in this room.
Spannend.
Dag.
Kijk eens.
Goedendag.
Het ziet er officieel uit allemaal.
Ja, ja. Sterker nog, dat is het.
Een mondkapje op, is dat verstandig? Is dat nodig? Kunnen we 1,5 meter?
Dat denk ik wel. Dat denk ik wel. Iedereen kon 1,5 meter in acht nemen. Dus.
Blijf zitten, mag het vasthouden.
Ben ik dat?
Als u gaat praten, dan komt dit erop als het goed is.
Okay. Ladies and gentlemen, Professor Oepkes, Mrs. van den Akker, under normal circumstances, as the mayor of Leiden, one is regularly invited to speak at special events, which is one of the perks of the office. However, COVID-19 has made those opportunities scarce. I too spent my working days in front of the computer screen to attend meetings, and I only get to see a few people for real. The opportunity to say a few words here at the farewell of Professor Oepkes is an outing for me, for which I am truly grateful. For obvious reasons, only very few people are physically present here. But fortunately, many more people are attending this gathering online, as I can see. After all, the LUMC Global Expert event on innovations in fetal therapy took place today, with participants from Sweden, the UK, Switzerland, Australia, Argentina, Austria, France, and Italy. Of course, I would have preferred to physically welcome all of you, to our beautiful town of Leiden. In that case, you might have been able to browse through our monumental city center and visit our resplendent museums. And possibly you would have spent some money with our local entrepreneurs. But unfortunately, all that is not in the books just now. And I advise you to make time for that on some other occasion. If you allow me, ladies and gentlemen, I now want to say something about Professor Dick Oepkes, whose farewell is the reason for today's activity. Dick Oepkes was born on the 1st of June 1960 in Nieuwe Niedorp, in the northernmost part of the province of North Holland. That is only 60 years ago, which means that he is reaching emeritus status at a fairly young age. A kind of prenatal retirement, so to speak. Actually, his patently fresh and fit appearance had already become clear to me when I saw pictures of him on the internet. Dick Oepkes studied medicine in Utrecht and received his PhD in Leiden in 1993, to be precise, and with distinction, to be exact. I looked up the subject of this thesis, ultrasonography and Doppler in the management of red cell allo-immunized pregnancies. To a simple historian like myself, that sounds pretty complicated, but you will all understand what it means. What I did understand is that it has to do with treating the unborn child, that this is a recent specialism, and that Dick Oepkes has been involved in the development of this professional field from the start in the late 1980s. He is considered to be an authority in this field. In 2012, he became a professor of obstetrics, particularly of fetal therapy, a new chair at the time. Professor Oepkes has helped develop innovative techniques, such as the introduction of Doppler as a less harmful alternative to amniocentesis to examine the well-being of fetuses. His publication in the authoritative New England Journal of Medicine changed clinical practice across the world. Since 2009, Professor Oepkes has been head of the National Fetal Therapy Center at the LUMC, which ensured that since that time, high quality care was made available in our country to fetuses who were ill. As a result, in the Netherlands alone, hundreds of babies have survived and grown up healthy who might have died otherwise. Moreover, Professor Oepkes always attached great importance to multidisciplinary cooperation, as well as to sufficient attention and support for parents who often face a lot of stress. Professor Oepkes also realized full well that international cooperation was indispensable to developing the professional field. After all, some pathologies only occur exceedingly rarely. And that is why Dick Oepkes has been a driving force behind a close collaboration with 7 other academic medical centers, such as the Karolinska Institute in Stockholm and University Hospital in Leuven. The list of publications by Professor Oepkes, ladies and gentlemen, is really exhaustively long. And the wide range of activities he undertook alongside his primary post is also very impressive. For instance, in 2004, he was one of the founding fathers of the MOET Foundation in the Netherlands. MOET is the acronym for Managing Obstetric Emergencies and Trauma. The foundation introduced a training method in the Netherlands that had been developed in Britain, and by now this course has become an obligatory part of the specialist training for gynecologists. Also, Professor Oepkes is an inspiring mentor and teacher who has supervised many students. Each and every one of them is now part of the future of fetal medicine worldwide. His huge social and interactive qualities made him a beloved doctor and a universally liked guest and speaker. That is going to change from now. Expectations are that Dick Oepkes will fully dedicate himself to further exploration of the full potential of his green egg barbecue. Otherwise, he will be totally immersing himself up in nature, which he loves and which makes him happy. Apparently, he is also a lover of blues music, and that is remarkable for the cheerful bon vivant Dick Oepkes so obviously is. For over 30 years, Professor Dr. Oepkes has made a very important and recognizable contribution to the development of fetal therapy, both at home and abroad. He is an authority in medical science who has elevated the care for the tiniest human beings to a higher plane. Thus, the countless awards and recognitions he has received are not coincidental. His trophy cabinet is full to the brim but a royal distinction was still missing. And of course, that state of affairs could not continue. Therefore, I am happy to tell you that His Majesty King Willem-Alexander has seen fit to fill this gap, and that on 18 February 2021, by royal decree, Professor Dr. Dick Oepkes was appointed Knight of the Order of the Dutch Lion, Ridder in de Orde van de Nederlandse Leeuw. And now I ask his wife, due to the pandemic situation, to place the order in his right place.
Okay, you have to tell me which side. Ga ik je redden? Ga ik je redden?
Fantastisch.
Kijk eens. Jeetje.
Ladies and gentlemen.
Hoera! Hoera! Hoera!
Bravo! Bravo! Hoera!
Dank allemaal. Thanks everyone for being here. Thank you very much, Mr. Mayor. This is completely unexpected and very well secret barbarian, as I think is the custom. It's a great honor. Is there for me to give a short speech? Is there is. Would that have to...
Moet je even naar de camera, ja precies.
Improvise.
Ja, dan kunnen ze hem ook zien, dat is dan leuk.
Yeah. So maybe I should start by showing this incredible honor award that His Majesty the King and the Mayor so very kindly presented to me today. And it's wonderful to see every one of you, so many friends from around the world for this occasion. Of course, it's great to hear a number of nice things to be told about your career that is, of course, widely exaggerated. And one of the things that I do need to say here that is, of course, extremely important and was also part of organizing this meeting today is that especially our field of fetal therapy exists by collaboration. It's a small field of people that are very dedicated to do exciting and often risky things to try and save unborn children. I think the whole field, basically everybody knows each other. It's a traveling circus of friends that have these qualities of both being extremely dedicated to spend their time and their efforts and their creativity to do this innovative things, and at the same time to work together, to be friends, to know each other, and as was mentioned, to socialize, drink and party occasionally in nice places. I think these things are all tied together. This is what is needed to advance such a field. And I have been very fortunate to have been given this chance to work in this field by the people who were so kind to hire me when I was a young doctor. Jack Bennebroek Gravenhorst was still here and the head of this department. And the founder of fetal therapy in the Netherlands, and Humphrey Kanhai, his right-hand man, and Inge van Kamp were the team at the time that gave me the chance to work in ultrasound and in rhesus disease, as was discussed before. those were very important parts of my early career. And then the collaboration with the colleagues and teachers at the time, Frans Klumper and Frank van der Bussen especially, made a great start for me and great opportunities. And I think the next thing that was vital to my career and also a big part of propelling the collaboration internationally was my time in Toronto with Greg Ryan, Rory Windrum, Gareth Seward, and the team that taught me a lot and also gave me a huge group of international friends that I've been in touch with in the 20 years thereafter. I've been very fortunate to have given these chances. I also think it shows that one of the important things to not only perform science and treat patients well, but to build a team of hardworking, smart, and trustworthy people that I think we have been doing in Leiden for a long time. The people that we have managed to hire here to work, we've been very fortunate that was such a great group, and that's also the reason I can safely retire and leave and barbecue on my green egg and play music, because I know that the team that I'm leaving behind consists of really excellent people that can continue in the same spirit. The ones that stay behind, Monique and Femke and Joanna especially, will continue to work hard, to do smart, innovative things, but also continue to keep their relations with international friends, hopefully soon again to travel around the world, to meet all of you in person again, and make sure that that I will be forgotten soon, because there's new things to do and new horizons to explore that do not need me anymore. I'm very happy to see the next generation being so talented. So thank you all very much. Hope personally that I will meet a lot of you in the near or more distant future again. Again, thank you, Mr. Mayor, for this great honor. Thanks my family, especially, for all the opportunities that they gave me to work hard and to travel and to meet all of you. I also promise that I will dedicate my time between the barbecue and the music to spend on my children, Teun and Marieke, and my wife, Elide, and supporting the family and the grandparents in the years to come. Thank you very much, and goodbye. I hope to see you again in the future, and preferably in real life.
Dank je wel, Dick. Thank you very much. Heel erg prachtig.
Van harte gefeliciteerd.
Ja, dank u wel. Ja. Had je iets in de gaten? Nee, hè? Nee. Nou, hier even. Ja. Oh ja. Misschien leuk nog even een foto met u.
Gefeliciteerd, Dick.
Hartelijk dank allemaal.
Dag.
Bedankt. Jullie ook bedankt. Hoi. Het is afgelopen.
Iedereen moet er even hadden. Hoera, hoera roepen.
Ja, dat hadden ze al gedaan.
Hoera.
Hoera.
Hoera. Hoera. Hoera.
Hoera.
Hoera.